Howdy, y'all. Welcome to today's podcast. In today's podcast, we have a great interview that I did with a good friend of mine, Dr. Pranav Sharma. Dr. Sharma is a urologist at Texas Tech University Health Science Center. A urologist is basically a doctor who specializes in the urinary tract. Now, he specializes in cancers of the prostate and the urinary tract as well. We discussed some of the risk factors for prostate cancer, some of the risk factors of testosterone and prostate cancer, how we can screen for it. And I was surprised by the different treatment modalities that people have or the doctors have when it comes to treating prostate cancer. So if you are wondering about what you can do to make sure you can optimize your prostate health, this podcast is for you. Now, because we talked about prostate cancer and other screening modalities, we're also going to talk about esophageal cancer. We'll talk about some of the what esophageal cancer is, the warning signs to look out for, and the steps you can take to reduce your risk. And then lastly, I'm a GI doctor. We also talk about colon cancer, and we also talk about some of the risk factors for colon cancer, the common symptoms to look for as well in today's podcast. So this podcast is all about prevention. Let's tune in and hear exactly what we need to do. Hey guys, I want to thank you so much for joining me today. I am so excited to have a friend of mine and a colleague of mine, Pranav Sharma. He is a board certified urologist currently working at the Texas Tech Health Science Center. So let me give you his credentials because it's pretty amazing what he's doing. And I'm so excited to have him as part of our podcast. So Pranav is a board certified urologic oncologist, and an associate professor in the Department of Urology at Texas Tech University Health Science Center in Lubbock, Texas. He completed his residency training at Henry Ford Institute in Detroit and his fellowship training in genital urinary oncology. See, I'm a GI doctor. I can't say these words, so please excuse my mumbling here. At the Moffitt Center in Tampa, Florida. His research and clinical interests include management of tumors in the genital urinary tract, including the bladder, prostate, kidneys, urethra, penis, adrenal glands, and testicles, as well as retroperitoneal sarcoma. So, Pranav, thank you so much for being on our podcast today.
Thank you for having me.
So one of the things we're going to talk about is, Joe Biden got recently diagnosed with prostate cancer. And, we've just seen more and more people in my clinic and maybe in your clinic as well, who are getting diagnosed with prostate cancer. And it's very confusing for both my patients and primary care doctors about what exactly do we do when it comes to screening. There's controversies. We don't know what's going on. So can you help set the record straight? How do we screen? What do we use? And what can patients and PCPs kind of understand when it comes to prostate cancer screening?
So, there's a lot of question marks about prostate cancer screening, primarily because the U.S. Preventative Service Task Force recommends counseling patients about the risks and the cons of screening before considering screening, which is a grade C recommendation. However, if you look at the American Urologic Association, the American Cancer Society, and any sort of the Society of Urologic Oncology, the guidelines are, or at least the recommendations are, to start screening men between the ages of 55 to 69 every other year. At a minimum, it's a PSA, of what we call a prostate-specific antigen blood test, which is a tumor marker specific for the prostate tissue, and is often elevated in prostate cancer. In addition to what we call the digital rectal exam, which is a rectal exam given by a health professional through the rectum to feel the posterior part of the prostate, which sits right in front of the anterior rectal wall. Now, I will admit, most men dread the rectal exam.
Yeah,
for obvious reasons.
I can tell you that from a GI doctor. Yes, they do.
They dread the rectal exam, especially because they're awake and we do it in the office.
Yeah.
I will say over time, we've realized the rectal exam is very subjective.
Yeah.
You're only feeling the posterior wall of the prostate because it sits right in front of the rectum. It's very dependent on the person that's doing the rectal exam. It could also be dependent on if there's a lot of stool in the rectal vault that may obscure the rectal exam. And you're, as I said, only feeling one side of the prostate. So I will say the PSA is probably more sensitive and specific compared to the rectal exam. However, the rectal exam can pick up other findings such as prostate size, prostatitis, So a young man with elevated PSA, one of the things we worried about is just prostate inflammation,
Yeah.
prostatitis. So if you do a rectal exam and you press on the prostate and it hurts, that's more of a clinical indication of prostatitis than prostate cancer. Prostate size, as I mentioned, especially since we're dealing with older men, it's always good to know their baseline prostate size because oftentimes, in addition to PSA elevation, they're coming in with lower urinary tract symptoms, and we're managing that too.
Yeah.
And then occasionally I've picked up rectal masses, even just with the rectal exam, that were just there, or hemorrhoids or something unrelated to the genitourinary tract. So even though the rectal exam is dreaded and can be very subjective, and you're only feeling one portion of the prostate, I would still consider it at least a mainstay of the initial screening. But I think at a minimum, men need to get PSA blood tests every other year between 55 and 69.
Now, sorry,
go
continue.
ahead.
No, continue. Sorry.
The AUA and the American Cancer Society also recommend screening high-risk populations. Yeah. So those are men with family history of prostate cancer or African-American men as early as 45 every other year up to age 69.
So let's say a primary care provider is, concerned about screening for prostate cancer, but, it's hard for a PCP, in their busy clinic to be able to do, a blood test, a rectal exam, and kind of really assess the prostate. And so practically speaking, in your experience, are those recommendations, practical for the everyday primary care provider who's seeing a lot of patients with multiple different complaints? Is that the best way and the only way that we have right now to really help manage these patients?
I think for PCPs, given how modern medicine is today with their busy clinics, 15-minute visits, I think at a minimum, they should just do the PSA screen, just include it in their panel of yearly blood work, but do it every other year. But it's very easy to include in their yearly physical. And I do think it should be included in their yearly physical every other year for men between 55 and 69. I think that, as I said, the task force did a disservice because they recommend counseling, but that's not practical in modern medicine.
Yeah.
And hopefully with this Biden cancer diagnosis, it will kind of raise awareness that maybe we should go back to doing some PSA screening, because if you actually look over the last 10 years, prostate cancer mortality has gone up compared to the 2000s. So if you compare 2010s to 2000s, we are actually losing progress in prostate cancer mortality. I think because of this task force and the massive drop in PSA screening.
So you feel like, in your opinion, being an expert in this field, that there's been confusion and maybe not clear guidance from the powers that be within some of the guidelines. And because of that, because I've noticed obviously with other PCPs that, the PSA testing and prostate screening may not be as given a priority as other cancers like colon cancer in my field, or breast cancer or things like that. So talk to us a little bit about the controversy and kind of what you're seeing, and delve a little bit more into that rise. It's incredible that we're seeing worsening progress of prostate cancer in 2025.
Right. And I think it's because the task forces recommend counseling men about the risks and benefits and then only consider screening. I think you end up with this mishmash of some PCPs basically doing screening and some PCPs basically not doing screening.
Yeah.
I think if you actually look at how many PCPs are sitting down and having a thorough discussion about the risks and the benefits of prostate cancer screening, which is a 30 to 45-minute conversation on its own, it's probably less than 5%.
Yeah.
So that's why I don't like this gray zone, because it doesn't really help anyone. And basically, the PCPs have to take it upon themselves to decide whether they do screening or not. And so you have some that do, some that don't, but it's not a universal across the board like breast cancer or colon cancer. And I think that's also partly our fault as urologists of not lobbying for that when this task force recommendation came out over 10 years ago, and really advocating for men's health. As you're probably aware, women advocate for their health much better than men.
Yeah.
And, this would have never happened with breast cancer,
Yeah.
of eliminating mammograms. And if you actually look at the number needed to prevent one death, it's very similar in prostate cancer to colon cancer and
Yeah.
breast cancer. So the actual effectiveness of screening is very similar across those three cancers.
Yeah.
Um, and so it was funny that the task force kind of targeted prostate cancer.
Yeah.
Some of that may have to do with some overtreatment of prostate cancer. As you're aware, a lot of prostate cancers can be surveyed because they're probably one of the slowest growing cancers in the human body.
Yeah.
And I think there was a period of time where we were doing a lot of overtreatment and a lot of men were having side effects and pushing back on whether prostate cancer treatment was really good in terms of long-term quality of life. But our pendulum for treatment of prostate cancer has shifted to a more patient-centric, catered approach. Even when we diagnose it, we only treat a small fraction of men now. But it's still important to get that screening to at least have the information and have the man have the information so they can make their own informed decision.
So two questions I want to sum off of that. So, just comparing to colon cancer, we've seen a rise. And because of that, we lowered the age for colon cancer screening to be 45 instead of 50. Obviously, in urology, you mentioned before, you've seen a rise in prostate cancer and just the late diagnosis and treatment. Do you anticipate still the 55 to 50 range still be the normal screening test that should be done? Or would there be a point in time where actually we may want to consider seeing it sooner or screening earlier besides those high risk populations?
So I anticipate actually we're going to see more diagnosis in younger men. And this is the primary reason.
Yeah.
We are having a lot more men now on something called testosterone replacement therapy.
Oh, yeah.
Now, testosterone itself, testosterone replacement, does not cause prostate cancer. There's no clear evidence that being on testosterone causes prostate cancer. However, in a man with undiagnosed prostate cancer, never had screening, right? Some of these men obviously won't get screening.
Yeah.
Because we know that it's controversial and some PCPs won't do screening. Some of these men with undiagnosed prostate cancer that do go on testosterone replacement therapy for other reasons, sexual function, low libido, lack of energy, improved muscle mass, improved energy. It is like throwing gasoline on a fire. And so that undiagnosed prostate cancer, the testosterone is almost causing that prostate cancer to grow like a weed.
Yeah.
And it will make it more aggressive. And so a previously potentially dormant undiagnosed prostate cancer could end up evolving into a much more aggressive prostate cancer that only comes to fruition after being on testosterone replacement therapy. Again, not because of the testosterone replacement therapy, but because it sets off, it's almost like throwing gasoline on a fire, as in it was undiagnosed, maybe dormant before, and then comes to light with this TRT replacement therapy. And as you're aware, we see a lot now of very young men, 20s, 30s, 40s, who are starting TRT.
Yeah.
Which is why it's so important, at least in our clinic, when we have to make sure that we're screening these men. Unfortunately, a lot of the people that are on TRT are still not getting screening.
That's very interesting. And that is so true. I've seen so many, like just in GI, obviously we don't see, the depth of, prostate issues at all in my clinic, but I see a ton of patients who are on TRT, and I've interviewed a lot of PCPs who, put patients on TRT. And I don't think a lot of patients and many PCPs put that correlation of maybe dormant, undiagnosed or low-lying, prostate cancer. It's not really a problem at that point in time, that putting patients on TRT may add that fuel to that fire. So I guess, my question, piggybacking off that, let's say you are a young man on TRT and, let's say that you are interested in, getting stronger for whatever reason, would you say the urology societies, I know it's controversial, I completely understand this, and it's an opinion, but should a PCP do a PSA and do it like every 1 to 2 years for somebody who's starting on TRT, or is that something that a patient should advocate for?
So anyone that starts TRT should get a baseline PSA,
Okay.
regardless of how young they are.
Yeah.
Now, let's say you check their PSA and it's completely normal and they're in their 30s. Well, honestly, you could probably wait another even 5 years before you check another one.
Yeah.
But you just at least need to get a baseline level. Additionally, if you start someone who's in the normal screening range on TRT, then they do need to be screened, every other year per the AUA recommendations.
Yeah.
So they probably at least need a baseline PSA if they're younger than the screening age. But if they're in the screening age, they definitely need to be screened per the AUA recommendations.
Okay.
Now, if their PSA is normal, I mean, you can continue with the TRT. There's nothing, further. It's not like you have to stop the TRT you're just making sure that there's not any concern for some undiagnosed prostate cancer.
Yeah. Yeah. Wow. That makes sense. I don't think a lot of people realize that. I think more importantly, a lot of patients don't realize that at least should get at least one PSA, regardless, of the age, and then you can change the surveillance based on risk factors and whatnot.
Right.
I don't think it's commonly done, to be frank with you. I really don't.
Yeah, and the problem is there's a lot of these men's health clinics all over, and they don't do they're basically just testosterone dispensaries.
Yeah.
I mean, basically just giving testosterone, not monitoring the levels.
Yeah.
And not really doing the due diligence and what's in the best interest of the patient. I mean, of course, the patients love it because it makes them feel great, but there are certain obligations that you have to do while you're on TRT just to make sure you're still within safety and doing what's best for the patient.
Yeah, absolutely. I mean, it's our job. It's no matter what, do the best for the patient and, make sure we advocate for the patient. Absolutely. It's our number one job. So you mentioned in a comment earlier that not all prostate cancers are necessarily treated, or, sometimes we watch them. So for my audience, who tends to be either patients or even PCPs, what is the approach for somebody who has an elevated PSA, you're concerned with prostate cancer? At what point in time do you consider treatment versus just watching, waiting? How do you make that decision?
So typically, in about 10 years ago, we used to do random prostate biopsies in the office using ultrasound.
Yeah.
That was traditionally how prostate biopsies were done. It was basically random samples of the prostate under ultrasound in anyone that had at least 2 levels that were abnormally high on a PSA level, which we say is above 4 on average, or a sudden rise in the PSA, like a slowly rising PSA. Nowadays, we rely a lot more on imaging before we move to a biopsy. And the gold standard is prostate MRI imaging. Similar to breast cancer, we have PI-RAD scoring for prostate cancer imaging. Similar to, I think they have like BI-RAD scoring for breast cancer imaging. So similar to that, we have PI-RAD scoring for prostate cancer imaging. So we get a MRI of the prostate with and without contrast, including diffusion weighted imaging. And our radiologists, who are amazing at reading MRIs now, they read hundreds a year, look at various lesions within the prostate and score those lesions on a scale of 1 to 5. Lesions that are 4 or 5 are considered clinically concerning for prostate cancer.
Yeah.
So 4 lesions typically have a 50% chance of having prostate cancer. 5 lesions have almost an 80% chance of having prostate cancer. 3 lesions, it's about 20%. So typically, we do targeted biopsies of the lesions that come up 4 or 5. So not random biopsies anymore, not ultrasound. It's MRI targeted biopsies of clinically concerning lesions, which dramatically cuts down on unnecessary biopsies and the number of biopsies that we have to do, and obviously reduces the pain for the patient as well. And we get a better true positive rate instead of a lot of false positives. And then obviously we rely on our pathologists reading the biopsies to determine what the best treatment is for the patient. Now, prostate cancer is graded on a Gleason score from a Gleason score of 6, which is the least aggressive form of prostate cancer, all the way up to 10, which is the most aggressive form of prostate cancer. Most Gleason score 6s now nationwide are just watched, regardless of age or life expectancy of the patient. We typically just survey Gleason 6 prostate cancer with semi-annual PSAs and MRIs every 1 to 2 years, and maybe a biopsy if something dramatically changes on the MRI or the PSA. But in general, Gleason 6s are typically surveyed. Gleason 7 is an intermediate risk cancer. We have to take into account the patient's comorbidities. What's their life expectancy? Unfortunately, it's very hard to determine that sometimes. Anyone with a life expectancy less than 10 to 15 years, again, would be a candidate for surveillance for an intermediate risk prostate cancer. Younger men, 50s and 60s, we definitely like to treat those men. So it's kind of a nuanced discussion when you get into intermediate risk prostate cancer. And then 8, 9, and 10 is high risk prostate cancer. It could potentially be lethal and develop into metastatic disease. And so we typically treat those cancers.
So, at least with colon cancer and colon screening, it's typically covered by Medicare and insurances. So for prostate cancer, is that typically the same way with the prostate MRI, the PSAs, the biopsies, or what is, in your experience, kind of what is typically covered by insurance, the screening test versus what may not be considered a screening test?
So here in Texas, we're actually pretty lucky. Everything is pretty much covered with Medicare.
Oh, that's great.
Other states, it can vary.
Yeah.
It also can vary based on insurance plans in other states. But in Texas, I will say I've never had issues with it getting covered, whether it be the PSA, the MRI, or the biopsy, as long as it makes clinical, as long as there's good clinical documentation.
Yeah. Well, there really is no excuse then to really honestly do it. I mean, if it's covered by insurance, it can save your life. Then I guess on those lines, like what are some of the barriers? Why aren't, besides maybe the unclear guidelines, what are some of the barriers for why this cancer is not literally eradicated when you have screening modalities, a blood test, an MRI, and a biopsy that may be covered? It seems like it should be eradicated or at least very well contained. Why is that? What are the hurdles for doing that?
Well, I think again, I think it comes back to the PCP's kind of haphazard screening. Again, if you don't specifically, I feel like maybe as physicians, if, we have so many things we have to worry about, especially a PCP in a single visit. So if you say you don't necessarily have to do this, I feel like there's a tendency that maybe you don't have to do it and you're not going to do it because it's one less thing you have to worry about.
Right, exactly.
Unless it's specifically stated that you have to do PSA screening, because the problem is if you start doing it regularly and then you get test results and then you have to make referrals. As you can see, it makes the administrative burden on an otherwise very burdened specialty, burdened primary care doctor even more. When they're already dealing with colon cancer screening, breast cancer screening, diabetes control, hypertension. And if you're going to say, well, prostate cancer may be optional, right? If you say, well, you have to do diabetes, hypertension, colon cancer, breast cancer, but guess what? Prostate cancer could be optional. The way that sounds is, okay, well, this is one less thing I have to worry about.
No, that's a shame.
And I think it starts from there. I think also when you bring up the fact that, we need to check your PSA, and then the patient's like, oh, what is a PSA?
Yeah.
and they're going to say, oh, this is to check for prostate cancer. I think there's also a stigma that if you go down this route of prostate cancer screening, they're going to take away my erections.
Yeah.
And I think that comes from, obviously, that is a side effect of treatments, but I think that's a huge stigma of prostate cancer treatment or prostate cancer or anything to do with the prostate is I don't want to lose my erections.
Yeah.
And to a man, and I know this sounds crude, sometimes the erections are more important than they'd rather they'd rather die with their erections than live without them.
Yes.
Because, obviously it's a very important part of a man's quality of life.
Yeah.
And so that's another stigma which we still have to improve, because nowadays with the advanced treatments, what men have to realize is there are so many options for prostate cancer treatment that can still preserve your sexual function. Or even if your sexual function is affected, we have so many treatments now to help with your sexual function afterwards, where you can still be cancer-free. And there's so many ways we can help you with sexual function, even in the case where it is affected by prostate cancer treatment.
So I think that's an important point. I think we should maybe talk about a little bit more, because you're right. A lot of men fear the loss of erection going through prostate treatment for prostate cancer and whatnot. So you're telling us that A, that certainly may not be the case, but B, if that is the case, we have a lot of other effective options to address that.
Correct.
Okay, that's good to know. So how has, I guess, along those lines, excuse me, how has prostate cancer treatment changed with respect to that? But also, what are the options that you can do? Obviously, we have surgery, but what other options can someone maybe expect if they know that they may be heading down a route where they may need, surgery or treatment for prostate cancer? And what are some of the newer options that may be available for them that maybe people may not be aware of?
So this is obviously one that we love to talk about, because it's so much technology has come in the last 15 to 20 years. Now, in terms of surgery, obviously the big one is robot.
Yeah.
Robotic technology has revolutionized prostate cancer surgery. It came out in 2000, and in the US nowadays, 99.99% of prostatectomies are done with a robot.
So what is, just for my audience, what is the benefit of a robot versus the traditional surgery? Why is that so much better?
So the prostate is located underneath the bladder, way deep in the pelvis, way deep in the male pelvis. As a matter of fact, if you try to open a patient's abdomen and look at the prostate, you have to cringe your neck and look under the pubic bone all the way down to try to even get a glimpse of a portion of the prostate.
Yeah.
In like a cadaver lab, for example. What the robot allows us to do is to visualize the prostate in a magnified fashion with amazing ergonomics using small robotic arms. It also, because of the magnification and the very delicate touch of the robot, allows us to preserve the nerves around the prostate, which control erectile function.
There we go.
These are called the dorsal neurovascular bundles. They run behind, posterior, and to the side, lateral, posterior lateral, to the pedicles or the blood supply of the prostate. And we sweep those away during the prostatectomy to try to preserve them as much as possible, which optimizes the patient's sexual function long-term. In the olden days, when open surgery, you couldn't really see them. And of course, most of the time they were removed with the prostate.
Yeah.
So the robot has really revolutionized prostatectomy surgery in terms of maximizing both sexual function and urinary control, because similar to the visualization of the neurovascular bundles, we can also preserve the sphincter mechanism of the urethra to try to preserve urinary control after prostate surgery as well.
Mm-hmm.
And so it's very rare that we see incontinence long-term after prostatectomy.
Wow. Yeah.
Now, looking at the other end, the other option being radiation.
Mm-hmm.
Radiation has also come a long way. We have IMRT, which is very targeted radiation, specifically that can be mapped to just the prostate without radiation damage to the bladder or the rectum. We have a novel device called the Space OAR rectal spacer. It is a gelatin spacer, and you'll appreciate this because then you don't have to deal with this in your clinic. It is a gelatin spacer placed between the prostate and the rectum to prevent radiation proctitis.
Yeah, that makes sense. Yeah.
And it basically eliminates the risk of radiation proctitis when delivering radiation to the prostate for prostate cancer.
Yeah.
And it's a little gelatin insert that's injected through the perineum between the prostate and the rectum, and it self-dissolves after 3 months.
Yeah.
So that's basically eliminated the risk of radiation proctitis.
Yeah.
And then IMRT in general has cut down on the peripheral damage to the neurovascular bundles to preserve erections. And then, of course, we have proton therapy.
Yeah.
Proton therapy is not universal yet. Obviously, there's only certain centers that have a proton therapy device, MD Anderson, certain places in Dallas. We don't have one in West Texas. It's very expensive. But it has the promise of treating the cancer with minimal side effects because it's by minimizing collateral damage. So instead of using photons like traditional radiation, it uses protons, and there's some crazy math stuff in there that I probably don't understand that supposedly reduces the risk of collateral damage and preserves both sexual function, continence, and also the benefit is less number of treatments needed compared to traditional radiation therapy. And then one of the newest things, which I'm very excited about, and we're working very hard to get this at our new cancer center here, is something called focal therapy, using high intensity focused ultrasound, or HIFU is the abbreviation. So for example, let's say you are a male concerned about sexual function. You want to preserve it. You want to preserve your continence. You're very active. You were diagnosed with a intermediate or low risk prostate cancer, maybe just in one portion of the prostate. All your other biopsies came out fine. You just had one concerning lesion that unfortunately showed prostate cancer.
Yeah.
And it's not a high risk prostate cancer. It's an intermediate or low risk. You're not crazy about surveying it because you're young and you're going to live a long time, and it's anxious to go through multiple PSA testing and biopsies and MRIs for the next 5 to 10 years. And unfortunately, with surveillance, there's still a 60% chance that the cancer could become more aggressive. So you're not thrilled about just doing surveillance. You don't necessarily want your whole prostate removed or your whole prostate radiated because of the side effects. So nowadays, we can use targeted high-intensity focused ultrasound to just treat that portion of the prostate. Almost like where they do partial lumpectomies in breast.
Yeah.
We're not doing like a partial prostatectomy, but what we are doing is using ablative therapy with high intensity focused ultrasound to just ablate that portion of the prostate to ideally treat the cancer, but preserve functional outcomes such as sexual function, continence, and it's a day procedure.
Yeah.
There's no catheter involved, which typically happens after a prostatectomy. You have to wear a catheter for 7 days.
Yeah.
Obviously, it's just needle punctures, no surgery involved, and it's literally an hour treatment. And it's something where hopefully we are working on strong to get to come to West Texas. No one's offering it here yet. It is available in the bigger cities in Texas.
Yeah.
But it is the future, in my opinion, of intermediate and low risk prostate cancer treatment for select patients that just have prostate cancer in one area of the prostate.
Wow, that's fascinating. And that's it's amazing how much technology has not only changed the treatment modalities we have in prostate cancer, but also, minimize the side effects that have dogged patients to not want to get either screening or even treatment for prostate cancer. I mean, it sounds like you for most of the concerns that patients had or people had, that they've minimized them as much as possible. I mean, as humanly possible.
And things are still in progress. I mean, we
Yeah.
have now even new PET scans coming in for prostate cancer. And the next step is to kind of combine these radioisotopes that target prostate cancer cells with not only having the prostate cancer cells light up, but delivering treatment to the cells that light up, what we call
Wow.
theranostics.
Yeah.
So that's, maybe 10 years away, but it's coming down the pipe as
Wow.
well.
Yeah.
So yes, this is why I think it's so important. And I think this is hard for a PCP because they don't know all this information.
Yeah. Exactly right. Yeah.
And so that's where the task force didn't really understand the full consequences of making this C recommendation. And obviously, if you are a PCP listening to this conversation, you're gonna say, well, prostate cancer screening is a no-brainer.
Yeah, exactly. That's exactly what I'm thinking. Why would no? Everyone should do this.
Yeah, exactly. It's a no-brainer. It's a simple blood test.
Yeah.
You just put it in. It doesn't really add anything. It's not that much morbidity. I mean, they're just getting the blood drawn anyway. And even with all these, at least historical side effects that we were hearing before, a lot of things have changed.
Yeah. Absolutely. I'm like thinking, yeah, you're doing a blood test anyways. You're getting like a hemoglobin A1C, add a PSA. If there's a concern, send them to your urologist. And given, worst case scenario, even if there is a lesion that's there, the treatments are so effective, the side effects have gone, very minimal. It seems like it's a win-win for everybody. The patient, the PCPs, the urology community. It seems like just that simple screening test can lead down a path where we can prevent prostate cancer, but even if there is cancer, we can certainly have options to minimize the side effects of treatment.
And even in situations, and I have been in this situation, like let's say you got a man, you diagnose with prostate cancer, he doesn't want anything.
Yeah.
He's absolutely doesn't care. You may say, oh, there's this option that can minimize your ED and sexual. He just doesn't want it.
Yeah.
At least he has the information.
Exactly.
So at a minimum, I think at least the patient has the information to make an informed decision on what's best for them.
Yes.
And if they decide they don't want anything done, even with all this new technology, which is well within their right, then at least they have the information and then they can make that informed decision themselves.
Yeah. I mean, information is key. And if they don't even have the ability to get that information by talking to someone like you, then, I think we're doing them a disservice and injustice by not at least giving them the information of options that are out there and having them make the decision, as opposed to, unfortunately, us as physicians, maybe not taking the initial step to get them screened, which isn't, it seems like really is a no-brainer to do that.
Right.
Okay. Wow, that's fascinating. So, Pranav, let's take a little bit of a break. We have like 10 more minutes. Is there anything else you want to talk about when it comes to prostate cancer that we didn't talk about so far? We can just go ahead and
just one quick thing.
Yeah.
In the new guidelines, it's very important to add, at least when you're doing, and this is more for urologists, but PCPs can do this as well. It's very important to ask about family history. We are now realizing there are certain genetic mutations similar to breast cancer, similar to ovarian cancer, associated with prostate cancer. And as a matter of fact, the BRCA mutation is one of them. So it's not only important you ask about family history of prostate cancer, it's also important that you ask about their family history in women of breast and ovarian cancer, because that BRCA mutation that can run within the family can affect the men in terms of their prostate cancer risk. So
Sure, I
it
don't
is
think a lot of people know that, even PCPs. So,
right.
for example, if your mother, BRCA, had a mutation, me as a man, I may think, all right, it's not a big deal. I'm not a woman. I'm not worried about this. But you're telling us that that can actually increase the man's risk of developing prostate cancer.
Correct.
Wow.
Correct. And there are other germline mutations like that, but we have there are so many genetic counselors now that can actually test you for these mutations in a
Yeah.
single, um, get your genetic um, workup done. And actually, there's a lot of mutations now that can be tested for.
Wow.
Uh, Obviously, not 23andMe used to be a thing, and I think now it's got. I think the accuracy of that is probably not something that I would advocate,
Yeah.
but a genetic counselor like at the UMC Cancer Center or Covenant Cancer Center, they're amazing. And if there's a strong family history, I would encourage those men to get tested for
Yeah.
those germline mutations, because of course that's not something that will just affect them; it'll
Yeah.
affect their sons and daughters,
Yeah.
and potentially their grandchildren as well.
Yeah. Well, so what are some of the other biggest risk factors for prostate cancer besides family history and age? Like, what are some other things that, hey, the patient or a PCP is like, I should kind of keep this in the back of my head for myself, for my patients. What are some other ones?
So in the veteran population, it's Agent Orange exposure, and this was
Ah,
actually done because um, amazing population-based studies over the last 60 to 70 years following these Vietnam veterans,
mm-hmm,
showing that there is a clear correlation and causation between Agent Orange exposure and prostate cancer.
mm-hmm,
African American men is another risk factor, and then smoking.
mm-hmm.
Of course, smoking, just like a lot of other cancers, increase your risk for prostate cancer. Maybe not as much as lung cancer or bladder cancer, but it is still a risk for prostate cancer.
So for those individuals who may have those risk factors besides, African American, which you said starts at the age of 45, would you consider screening them sooner than the normal age around 55? Would that be a consideration for a PCP, or would it still be, hey, we're still okay at 55 unless you're African American, which you said it should be earlier?
Family history, definitely 45. And if you test positive for one of those germline mutations, 45. So I think those are probably the two other indications to start screening 10 years earlier.
Okay, that makes sense. Perfect. Well, Pranav, we had a long conversation. There's so much we can talk about when it comes to urology. ED, erectile dysfunction, pelvic floor issues. But I want to be respectful of your time, and I appreciate you coming on. I will give I'll give my audience. If you guys want more information on other things going on in the urological space. We would love to see if we can have Dr. Sharma back on and for future podcasts and videos to talk about other things as well. But is there anything else you can leave my audience with when it comes to prostate cancer screening, what we know about Joe Biden and kind of other things you want our audience to know or PCPs to know?
Well, I would say, as I said, prostate cancer screening, I think, is important. I think it is underutilized. I think that hopefully one at least good thing that may come from this public diagnosis is maybe a shift towards going back to screening appropriately per
Mm-hmm.
what the AUA and the American Cancer Society suggests. And it is funny because there have been other high profile cases of prostate cancer. Ben Stiller had
Yeah.
prostate cancer. And so it is the second most common cause of cancer related death in men,
Mm-hmm.
and the most common diagnosed cancer in men.
Yeah.
So this is not something that's, rare.
Yeah.
I think we have evolved so much in the last 10 years that I just want to make sure the PCPs and the patients know that we take a much more personalized, catered approach with each prostate cancer diagnosis. And there is such a plethora of available treatment options that can be catered to absolutely minimize side effects of treatment.
Yeah, I think you made a yeah, it's amazing now the treatment options that you've talked about.
And as a matter of fact, now we're even doing big testosterone replacement therapy after successful treatment of prostate cancer to not only preserve sexual function, but even enhance sexual
Yes,
function after treatment, which is safe in a successfully treated patient.
yeah.
So there are so many options now, and technology has come a long way that I feel like prostate cancer is not a disease that anyone has to die from in the future.
Yes. I think you've made that. I think you clearly demonstrated. Number one, I agree with you. There should be no reason people should die or even have concerns about prostate cancer. It should be universally screened. It seems like a no-brainer. Simple blood tests. But not only that, the treatment modalities are so effective. They're so catered with minimal side effects that there really should not be any excuse for a patient to not advocate for their own health. But also, too, a PCP, just get a simple blood test, add it on, and then knowing that we have so many different options for therapy, you can educate your patient that even though you have an elevated PSA, there's a risk factor, it's not the end of the world. And there are a lot of options for them for treatment and side effects.
And an elevated PSA doesn't necessarily mean that you have prostate cancer.
Exactly right.
Again, we have such advanced MRI imaging, PET imaging that's very sensitive and very specific. And there's a multitude of other reasons you can have high PSAs, whether it's prostate enlargement, prostatitis. But we have now ways of teasing out what's real and what's not, rather than just subjecting you to a biopsy.
Yeah.
Everyone was afraid that as soon as they saw the urologist with elevated PSA, they had to have a biopsy, and and they didn't want a biopsy. Well, guess what? Now you don't have to do that. We have so much more advancements that when we say you need a biopsy, it's really because you need a biopsy. We're not just trying to torture you anymore. So
that's true. I remember in the days of when I was in med school that we had those random probes, ultrasound in the clinic where you're just biopsying everything. I was like, wow, this seems pretty intense, but I'm glad things have changed.
Yes.
Whatever I start to turn around the age where I need to get my PSA checked as well. Well, Dr. Sharma, thank you so much for getting on this podcast. So if patients are interested in getting screened, if they want to come see you, if they want to find out kind of what's going on, or if a PCP is interested in having them send a patient towards you or towards your office or your department, what is the best way for them or our patients to maybe get a hold of the urology department?
So our clinic number is 806-743-1810. That's the best way to request for a new patient visit.
Perfect. We'll put all that information on the show notes below. So if anybody is concerned about the prostate, or if a PCP is wanting to get a patient in for any issues in the urological space, we'll put all the information in the show notes below. But Pranav, thank you so much for being on. I appreciate it, man. You did a great job. You gave some great information, and you got me inspired to make sure that my patients, even though they're coming for GI issues, hey, man, just get your PSA done. It's simple. You're getting screened anyways. Might as well have your PCP check that so we can make sure everything is going on and doing okay with respect to your organs inside your body.
Thank you, Dr. Islam. Thank you.
Thanks, man. In this section of the podcast, we'll be covering what esophageal cancer is, the warning signs to look out for, and the steps you can take to reduce your risk. So this video was inspired by a patient I saw a couple of weeks ago. He was a young man in his mid-30s who's having chronic acid reflux. Now, his reflux symptoms were not that bad, meaning he didn't have them every single day, but he was having for quite some time, for decades, ever since he was a teenager. Off and on, he would have acid reflux, and then what brought him to me is that he started to have trouble swallowing. Food was getting stuck. He thought, not a big deal. This happened in the past and went through it. I just swallowed some water, not a big deal. But he did come to see me because of his symptoms. We actually did an upper scope on him, and unfortunately, we actually diagnosed him with esophageal cancer. Now, it shocked me because this is one of the youngest patients I've ever diagnosed with esophageal cancer. So it really just brought me to oh my gosh, wow, we are seeing such a rise in different cancers in younger individuals. This is why I wanted you to know what's going on so you can make sure this doesn't happen to you. We're gonna do a quick little science dive here, but your stomach has cells called columnar cells. These are cells that are made to hold acid. This is why your stomach can have acid and not have any significant damage that's there. We use that acid in our stomach to help break down food into its smallest component. And we chug things along and help kind of break down the food so we can make sure we absorb them in the small intestine. Your esophagus has what are called squamous cells. These cells hate acid. It doesn't like that. In fact, the only function of the esophagus is to move things from the mouth to the stomach. What happens is that when acid goes from the stomach into the esophagus, your esophagus hates this. You're like, oh my gosh, I don't want this. I want to get rid of it. So it induces what's called a peristalsis to move that acid down in the stomach. Now, normally we all have acid going up. That's typically normal because as a consequence of swallowing, eating, drinking water, that valve between the esophagus and stomach opens up longer and more often. So because of that, acid will go up into the esophagus and eventually it'll just go back down. Not a big deal. But what happens is that when you have chronic acid reflux going into the esophagus, that's where the issue occurs. Because your esophagus does not like to have acid, it tells itself, oh my gosh, I'm getting way too much acid. We need to protect the esophagus. And so what happens is that these cells start moving from esophageal cells, remember squamous cells, and it converts to stomach cells, which are called columnar cells. But the issue is that that conversion does not stop. You actually have a mutation that occurs because of that change in that chronic acid reflux. So instead of stopping at columnar cells, it progresses into precancerous cells, then eventually cancerous cells. And so this leads to the second point. What are the causes of acid reflux? And the most common cause is chronic acid reflux. Now, the important thing you want you to know, now it does not have to be acid reflux or heartburn every single day. No, it doesn't. This is the scary thing for a lot of my patients. A lot of my patients assume, rightly so, that the risk for developing esophageal issues is when you have daily acid reflux. It's debilitating. It burns so much. But when you look at these studies and in clinical trials for the risk factors for esophageal cancer, it's not necessarily that. It is decades of acid reflux, intermittent acid reflux. It comes and goes. It feels some burning. You have to take the occasional Tums, maybe an acid medication every couple of weeks and it goes away. But it's the length of time of acid reflux that predicts your risk for developing esophageal cancer. So it's chronic acid reflux, chronic heartburn, chronic regurgitation that are the triggers for esophageal cancer. Now, the other biggest risk factor is a condition called Barrett's esophagus. So do you remember when I told you that the cells in the esophagus don't like acid and it switches from squamous cells to columnar cells? Well, those columnar cells are precancerous cells in the esophagus, and that is called Barrett's esophagus. And we can see actual Barrett's esophagus when I do an upper endoscopy to see exactly what's going on. These are particular cells that when I see with an upper scope, tell me you have precancerous cells out of there. And there are a couple of risk factors within those cells that can predict the risk for you developing esophageal cancer. We'll put a playlist about Barrett's esophagus at what you need to know. Another risk factor is smoking and alcohol. And the combination of the two not only doubles your risk for developing esophageal cancer, it can quadruple your risk. So smoking in and of itself is a risk factor. Alcohol in and of itself is a risk factor, but both combined is almost double, triple, or 4 times your risk of developing esophageal cancer. Obesity is a risk factor for developing esophageal cancer. The reason central obesity specifically is a risk factor is because all that pressure on your abdomen will cause the valve between the esophagus and stomach to be open longer and more often. And once again, it's that chronic acid reflux exposure that increases your risk of developing esophageal cancer. And then lastly, dietary factors, they certainly play a role. So a diet that's high in red meat, processed foods, low in fiber, fruits and vegetables will increase your risk of developing esophageal cancer. And then lastly, any other risk factor for chronic GERD, acid reflux will also increase your risk of developing esophageal cancer, whether it is a large hiatal hernia, whether it is slow motility in the esophagus, like for conditions like scleroderma or other conditions like that in which the motility is impaired. So what are the symptoms of acid reflux? The most common symptom, and the one I want you to know, is trouble swallowing. Food, water, pills getting stuck. This is why I have to stress to my patients that if you feel like things are getting stuck, that is 100% not normal. It is not normal for things to get stuck in your esophagus when you're eating, swallowing, or drinking. That is never normal. Even one time is not normal. And so that is called dysphagia. So if you ever notice that things are getting stuck, even on the occasional basis, that could be your first warning sign. Now, other warning signs include vomiting blood, weight loss, poor appetite, getting fuller earlier and quicker. These are all signs of some type of cancer, especially esophageal cancer. But the most common symptom and common sign of esophageal cancer is trouble swallowing. So how exactly do we diagnose esophageal cancer? Well, we do exactly what we did to this patient. We do what's called an upper endoscopy or an EGD. This is where I actually go down with a small little camera and I can take a look and I can actually see the cancer myself. And I can see visually what is going on. And in most cases, I can diagnose somebody with esophageal cancer there. And then once we do that, we have to do staging, whether it's called an endoscopic ultrasound, a CT, a CAT scan, or other tests like that. What do you need to know to make sure you don't develop esophageal cancer? Now, this is what I would have told my patient years and years and years ago, because early detection not only is key, it can be preventable. We can prevent you from developing this cancer, because by the time you have had cancer of the esophagus, it is a very difficult road to go down. So number one, if you ever feel like things are getting stuck, whether it's water, food, pills, breads, meats, whatever, that is the first sign that something needs to be addressed, because what that tells me is that you already have the precancerous lesions and the inflammation that can lead to esophageal cancer. It doesn't matter if it's one time. It doesn't matter if it's just one small little pill. Anytime something gets stuck, that is never, ever normal. And so if that happens, come see someone like me so we can see what's going on and get that investigated. Number two, if you have chronic acid reflux for a long time, 5 to 10 years of chronic acid reflux, come see someone like me so we can see exactly what is going on. Once again, it is the length of time of damage that predicts your risk of developing esophageal cancer, not the severity of reflux that you have. Number three, if you smoke and you drink alcohol, these are also whammies to your risk for developing esophageal cancer. So if you want to decrease your risk, stop smoking and stop drinking alcohol. Number four, manage your acid reflux. If you have acid reflux symptoms, come see someone like me. This is literally our job. I've been trained to help you with your acid reflux. And with my investigation, I can determine, can we try natural therapies, lifestyle changes, dietary modifications? Do we need to consider medical therapies for your acid reflux? Or do you have an anatomical reason that's going to make it harder for us to treat you medically or naturally? Do you need to have surgery for your hernia? Do we need to do weight loss surgery? Come see us, because if we can manage your acid reflux, we can certainly decrease your risk of developing esophageal cancer. Eat a healthy diet. Focus on foods that are low in nitrates, high in fiber, high in fruits, high in vegetables, low in meats, and processed foods. These are the literal risk factors, dietary-wise, that can change your risk for developing cancer of the esophagus. And then lastly, probably more important, get regular checkups. Get an upper scope. We can see literally what is going on. It takes about 15-20 minutes to do. You were asleep the whole time. There's no prep, no clean out, but I can see your risk factors. I can find out what's going on. I can see if you had any other lesions, so we can fix it, get it taken care of for you. Don't be scared, because we can find out what's going on and get you taken care of. When it comes to esophageal cancer, the important thing I want you to know is early detection is critical. Symptoms like trouble swallowing, weight loss, or persistent heartburn should not be ignored. If you experience these, come see us. Visit us at gastro.com for more information. I want to thank you for watching. I hope this video was helpful for you, and I hope it can save a life. This is a video I wish my patient would have seen years ago, so we could have prevented him from developing esophageal cancer. Lastly, in this part of the podcast, we'll discuss what is colon cancer, the common symptoms to watch out for, and key ways to prevent it. So before we begin, let me talk to you about a patient of mine named Brian. Now, for a while, Brian was having a lot of different vague abdominal symptoms: abdominal pain, weight loss, intermittent rectal bleeding, some change in his bowel habits. Now, he didn't really make anything of it. It wasn't all the time. And he attributed his rectal bleeding just to some hemorrhoids. Not a big deal. He kind of blew it off. But his symptoms got worse and worse and worse. He came to see me, and we talked about the symptoms, and we decided to go ahead and undergo what's called a colonoscopy. And when we did that, unfortunately what we found was colon cancer. Brian was only in his 30s. He actually ended up having an aggressive form of colon cancer. Now he's currently going through chemotherapy and radiation therapy, but because we found his colon cancer, we actually have a better prognosis for him than if we were waiting longer or if we had a more advanced disease. So what exactly is colon cancer? Colon cancer is a cancer in what's called the colon, or the large intestine. The large intestine mainly is an organ to help move things through from your small intestine to the rectum. It acts as a superhighway to push that stool to get it going and moving through there. But at times, there could be a DNA alteration that can lead to progression of what's called a polyp, which is a precancerous growth that over time can lead to colon cancer. Unfortunately, we are seeing colon cancer in younger and younger individuals, and we don't quite know why. And typically, this cancer develops in what are called precancerous polyps. Here's the scary thing about polyps is that they don't cause symptoms until it's too late. So you don't even know that you have polyps. You don't feel a polyp. You can't tell that you have a polyp. And in most cases, these polyps grow continuously inside your colon unless we actually take a look with a colonoscopy to find that polyp and remove the polyp at that same time. This is why procedures like a colonoscopy are invaluable, critical, and life-saving to find these polyps before they become cancer. We can get rid of those polyps and minimize or even eliminate your risk for developing colon cancer. And this is also why we do the colonoscopy when you're feeling good, when you're not having symptoms, when it's due because of your age. Because our goal is to find the issue before it becomes a problem, before you have symptoms and before it's too late. So who exactly is at higher risk for developing colon cancer? Here's what you need to know. Number one, if you have a family history, especially if it's in a first-degree relative, mom, dad, brother, sister, this automatically increases your risk for developing colon cancer. Number two, certain diets can make it more likely for you to have colon polyps and colon cancer. Whether it's a diet that's low in fiber, high in red meat, this is a bad combination to make it more likely for you to develop colon cancer. Number three, having a sedentary lifestyle, we're just chilling, not doing anything, not exercising. Not only is that bad for your overall health, it is bad for your colon and increases your risk for developing colon polyps and colon cancer. 4, diabetes. Insulin resistance is a risk factor for a lot of different problems, whether it's heart disease, whether it's problems in your pancreas, but also increases your risk for developing colon cancer. Obesity. The bigger you are, the more likely you're going to have colon polyps, and the more likely you're going to have colon cancer, including aggressive colon cancer. Then lastly, smoking and alcohol. That combination makes things substantially worse. If you're smoking and you're drinking, don't do it. Don't do either one. They're both bad for you, but that can increase your risk tremendously for developing colon cancer. So what exactly are signs and symptoms of colon cancer? Like I mentioned before, colon polyps, which are the precancerous growth before it goes into cancer, typically doesn't cause any symptoms. It's not a big deal. But sometimes there can be subtle signs that be going on inside your body that makes me wonder, is there something else going on? Or could there be a sign of colon cancer? Here's what you need to know. Number one, rectal bleeding. I tell this to everyone. Do not ignore bleeding. Don't assume it's just a hemorrhoid or a tear. Don't ignore it. It doesn't matter how little it is. It doesn't matter how young you are. Rectal bleeding is a cardinal symptom and sign of something bad is going on. Don't ignore it. Don't forget it. Get that checked out. Number two, unexplained weight loss. Like my patient Brian, he had a weight loss he could not explain. Now I know a lot of people out there are happy. All right, I lost weight. This is not the way I want you to lose weight. You should not have unexplained weight loss. If you have that, that means something is causing you to have all that weight that's being lost. It's taking up energy, and that thing could be colon cancer. Number three, persistent abdominal pain. Remember that colon cancer grows into that colon, and that cancer can cause really bad lower abdominal pain. If you're having pain that's not resolved, we don't know why, get a colonoscopy to find out what's going on. Number four, weakness, fatigue, or anemia. Anemia is never normal. That is a loss of blood. We need to find out why. And weakness and fatigue could be a sign of you being anemic. So if you're feeling weak, you're feeling tired, get your blood count checked. If you are anemic, your blood count is low, you know what to do. Come see someone like me to get a colonoscopy. Lastly, a change in your bowel habits where you were regular, then all of a sudden, you have diarrhea, you have constipation, or maybe it's the other way around. Before you were always having diarrhea and now you're having regular bowel habits or you're constipated. If you have a new change in your bowel habits, get that checked out. It could be a sign of something bad going on. So what can you do today to minimize your risk for developing colon cancer? If you have a family history, you know somebody who has a risk factor, here's what you need to do. Number one, change your diet. Add more fiber, add more fruits, add more plants. We have seen in studies after studies after studies that this change in your gut microbiome alters the pathway that can change and modify your risk for developing colon cancer. Decrease meat, increase vegetables. This is something you can do to improve your colon and to prevent that risk. Number two, don't drink, not even in moderation. Drinking sucks, it's not good for you. If you can avoid it, this is going to help out. If you want to drink, that's up to you, but do as minimal as you can. Number three, don't smoke. Come on, why are you smoking? It's terrible. There's literally nothing good whenever you smoke. cut it out, stop, do what you can to stop smoking. Number 4, get moving, get some exercise. Even a little bit of exercise will substantially decrease your risk for developing colon polyps and colon cancer. Even going for a brisk walk, that's all you need to do to start off that process of helping out to minimize your risk. Then lastly, maintain a healthy weight. If you are obese, find ways to help minimize that obesity, whether it's diet, whether it's lifestyle changes, whether it's exercise, whether it's medications or surgery. Do what you can to get your weight down. Now, the number one thing you can do today to decrease your risk for developing colon cancer is, drum roll please, get a colonoscopy. I know. Listen, no one ever wants to get a colonoscopy. I know this. I see this and I hear this all the time. Listen, this is literally the best test you can do to prevent colon cancer. Every single GI doctor in the world agrees. We can find a polyp, we can get it before it becomes cancer, we can remove it and pretty much eliminate your risk for developing colon cancer. If you are on the fence about getting a colonoscopy, get it done. It can save your life. If you have a loved one who's not gotten one, tell them to get one. It can save their life as well. This is literally like 100% the best thing you can do to prevent colon cancer by far. More than anything I can give you today, get your colonoscopy, get it done. It can save your life. Here's my call to action to you. If you haven't already, if you're the age of 45, you need to get a colonoscopy. If you have a family history, get it done sooner. Or if you have symptoms, get it done sooner. Call your doctor today. Call me, your poop guru, to get your colonoscopy done. Save your life and save a loved one as well. As we wrap up today, I want to take a second and invite you to share this video and podcast with anyone you think may benefit from it. Maybe it's your parents, maybe it's a spouse or a friend. Let's make sure they get solid gut health information to improve their gut from the inside out. Secondly, I would love to have an opportunity to work on your gut health with our team at Lubbock Gastro. Visit us at lubockgastro.com to make an appointment today or call our office at 806-696-4440. We can see you in person and via telehealth as well. Well, thank you for watching. I look forward to seeing you guys on future videos.